Hello everyone. Welcome to this short tutorial from Pathology Made Simple at ilovepathology.com. This is the part 4 of renal pathology series which I am covering in this channel. In this part, let's learn about acute post-streptococcal glomerulonephritis. If you are new to this channel, I would suggest you to go and watch the earlier 3 videos because that would help you in understanding this particular topic. In the next 10 or 15 minutes, we'll be discussing what is the definition of acute post-streptococcal glomerulonephritis. We will look into the etiopathogenesis, the morphology, the clinical features, the laboratory findings, and then a bit about treatment and prognosis of acute post-streptococcal glomerulonephritis. So basically, acute proliferative glomerulonephritis, or it can be a post-infectious or an infection-associated glomerulonephritis. These are cluster of diseases which are characterized histologically by diffuse proliferation of glomerular cells, and that is also associated with influx of leukocytes, particularly neutrophils, and they are typically caused by immune complexes. Okay, that means there has to be some amount of antigen for immune complex formation, right? And what are those antigens? They can be either of exogenous antigen or can be endogenous antigen. The most common example for exogenous antigen is this post-infectious cause, it is caused by streptococci, whereas endogenous antigen, the most common example we cite is lupus nephritis. So if you recollect what we discussed in the earlier video, that is a pathogenesis of glomerular injury, we saw that glomerulonephritis can be caused either by immune mediated causes or non-immune mediated causes, or can be by activation of alternate pathways, right? So among the immune mediated, we learnt about in situ complex and circulating immune complexes. So even in acute post streptococcal glomerulonephritis, we will be learning more about this immune mediated injury to the glomeruli. Now let's look at what streptococci is. We all know that streptococci is a gram positive cocci in chains, and then they are classified into different types based on the type of hemolysis they produce on blood agar plates into, whether it depends upon whether the hemolysis is partial, complete, or there is no hemolysis. And they are classified as, if it is partial, it is alpha hemolytic. If the hemolysis is complete, it is beta hemolytic. And if there is no hemolysis, this is gamma hemolytic. And beta hemolytic further can be classified based on their ability to produce a protein called streptolysin O into two groups. One is group A and then group B. The example of group A beta hemolytic streptococci is your Streptococcus pyogenes. The majority of them, they produce streptolysin O. The group B, the example being group B beta hemolytic, the example being Streptococcus agalactiae. What is the causative organism? We all know that it is group A beta hemolytic streptococci, that is your Streptococcus pyogenes. But then remember, not all streptococci result in this renal disease. There are some strains which are called nephritogenetic, which means they are the ones which affect the kidneys. What are these strains? These are the types, types 12, 4 and 1, which are identified by typing the M protein on the bacterial cell walls. Okay, so remember, the causative organism is the group A beta hemolytic streptococci, and the nephritogenetic strains are type 12, 4 and 1. Now for an immune complex to be formed, the most important thing is an antigen, right? Now what is this antigen on the streptococci or from the streptococci which is important? And the most important antigen is the streptococcal pyogenic exotoxin B, which is SPEB. In most of the cases of post-streptococcal glomerulonephritis, it is found that this antigen is the one which results in the formation of immune complexes. Now, once you know the antigen, we should understand that this antigen can be planted, it can go and sit there on the subendothelial location. So there in the subendothelial location, immune complexes are formed, and that is in situ formation of immune complexes. And we know that once the immune complexes are formed, they are the ones which results in inflammation. These antigen can form immune complex within the circulation, and then they are circulating all over, and then they are trapped. These are circulating immune complexes, as we saw in the pathogenesis of glomerulonephritis, right? And these circulating immune complexes then finally can be trapped within the glomeruli, and these trapped complexes are the ones which results in inflammation. Okay, so remember, the immune complexes can be formed in situ or the circulating complexes can be trapped in the glomeruli, ultimately leading to inflammation. The third important way this antigen can affect is they can directly activate complement and then result in inflammation. Once the immune complexes are formed, due to some unknown reason, they dissociate and then migrate across the glomerular basement membrane into subepithelial side. They reform on the subepithelial side of the glomerular basement membrane. So initially, these immune complexes are located in the subendothelial location, and finally, they are located in the subepithelial side of the glomerular basement membrane. That is what you need to understand. Okay, let's see this by illustration. So these are the streptococcal pyogene exotoxin B antigen, okay, which is there in the subendothelial location, and that is an antibody, and the antibody is usually IgG antibody, and then there is formation of immune complexes there. This is in situ immune complex formation, which finally dissociates and migrates through the basement membrane into the subepithelial location. And let's see the circulating immune complexes, where the antigen antibody complexes are formed in the circulation, and then they are trapped in the glomeruli in the subepithelial location. So now once we know that there are immune complexes in the glomeruli and then that results in inflammation, now let's see what is the morphology of acute post streptococcal glomerulonephritis. So under light microscopy, let's look into these three aspects. What are the findings in glomeruli, tubules and interstitium? So first we look into glomeruli. Glomerular involvement is diffuse and global. Now what does that mean? Diffuse meaning, if you take renal biopsy, the majority of the glomeruli should be involved. More than 50% of the glomeruli, if they are involved, it's called diffuse involvement. And within a given glomeruli, the entire glomeruli is involved, and that's called global. So remember, PSGN, the light microscopic finding, it is diffuse and global. So what really happens here? The glomeruli are enlarged and hypercellular. Now, why are they hypercellular? And that's because of infiltration of inflammatory cells, and then there is proliferation of endothelial and mesangial cells. Okay, so remember, look at this. The whole Bowman space seems to be filled with glomeruli. Glomerular tuft, and you hardly see any capillary lumen. This is an enlarged hypercellular glomeruli, and this enlargement is basically because of proliferation of the endothelial cells, proliferation of the mesangial cells, and the infiltration of inflammatory cells. In advanced cases, what happens is there can be formation of crescents. So what are these crescents? Crescents are basically proliferation of the epithelial cells of the Bowman's capsule along with inflammatory cell infiltrates. So that is a crescent formation. This is in advanced cases. So ultimately what happens? That results in obliteration of capillary lumen, thereby reduction of glomerular filtration rate. So you can find red cell casts in the tubules and interstitial edema and inflammation, of course, in the interstitium. Now let's look into the immunofluorescence findings, immunofluorescent microscopy findings and electron microscopy findings. Immunofluorescent microscopy, as we understood in the early tutorial, the deposits are granular because you can find these deposits of immune complexes, particularly immunoglobulin G. That's what we saw, right? And then you also have C3, the complement. Very rarely you can even find IgM deposits, and these deposits, because of subendothelial location, they're not regularly arranged. That's why the deposit is granular. So what do you find in electron microscopy? These are electron dense deposits which can be seen in the subepithelial location or subendothelial or mesangial or even within the glomerular basement membrane. But the most common or the characteristic feature is presence in the subepithelial location as humps. They are characteristic of post streptococcal glomerulonephritis. Now let's understand the clinical features of post streptococcal glomerulonephritis. A typical case scenario would be like this. This would be a young child who had a sore throat or a skin infection and has recovered. Usually, there will be 1 to 2 weeks of asymptomatic period, and suddenly, they present with malaise, fever, nausea, oliguria, and hematuria. Particularly, they will be having smoky or cola colored urine. They also have periorbital edema, and that's because of mild proteinuria. Okay, periorbital edema. Why is that periorbital location is most favored in these cases? That's because periorbital region has lots of lymphatics, which normally are there because they have to drain lots of secretions from the eye, from the in the form of tears or even the nasolacrimal duct, So any changes in the interstitial component, that is manifested in the periorbital area. That's why the most common manifestation would be periorbital edema. In these cases, there will be mild to moderate hypertension, and that's because of sodium and water retention due to inflammation, and also could be because of increased secretion of renin by juxtaglomerular apparatus. Okay, basically this is hypertension via renin angiotensin system. In adults, the scenario would be different. They have more atypical features where they can present with sudden onset of hypertension and edema along with elevated blood urea nitrogen. Now, what are the laboratory findings? Urine examination, there would be hematuria and proteinuria. Serum examination, you can find elevations of anti-streptococcal antibody titers, anti-streptolysin O to be more specific. There can be decline in the serum concentration of C3 and other components. Now, how do you treat these patients? Most often, the treatment would be supportive treatment in the form of managing blood pressure by giving diuretics, by salt and fluid restriction. And then, do you think there would be any role for antibiotics? Actually, no role, because the infection has typically occurred weeks earlier, and now the immune complexes have already formed. But what really happens is, if the streptococcal infection is confirmed during your investigations, or if you suspect that there could be some amount of infection still left behind, and that is when antibiotics need to be included, basically to eliminate the offending agent. What is the prognosis? It depends upon whether we are dealing with children or adults. In children, majority of the cases, 95% of the cases, they recover renal function with just conservative therapy. Less than 1% of cases, they become severely oliguric, develop a rapidly progressive glomerulonephritis, and then in the rest of the cases, there will be slow progression to chronic glomerulonephritis. Whereas in adults, it's less benign, they or only around 60% recover promptly, but then 30 to 35% of the cases in adults, they have persistent hematuria, persistent proteinuria, and hypertension. And in the rest of the cases, they progress to rapidly progressive glomerulonephritis or even chronic glomerulonephritis. So that's about acute post streptococcal glomerulonephritis. Remember, it is basically caused by immune complexes. One antigen, Streptococcus pyogenes exotoxin B, which can form in situ complex, or the circulating complexes can get trapped in the glomeruli, leading to inflammation. We talked about the glomerular pathology, we talked about the morphology. The most important morphology you need to remember is enlarged and hypercellular glomeruli, right? So that's about post streptococcal glomerulonephritis. Thank you for watching. If you have liked this video, hit the like button, do comment. If you have any queries, don't forget to subscribe if you are new to this channel, and please do share if you find this video useful. In the next video, we'll come out with another important glomerulonephritis. Stay tuned. Bye bye.